Hi, everyone. This is Kate Gillis. I am the Senior Communications Specialist with the Evidence Project, and I'm delighted to welcome you to our webinar today. The title is Generating Evidence and Impacts Through Implementation Science, Perspectives from Family Planning, Reproductive Health, and Maternal and Newborn Health Researchers and Policymakers. We have a really fantastic group of 5 panelists today. They'll be talking about the value of implementation science from their experiences with family planning, reproductive health, and maternal health research programs and policy. So I have a few housekeeping notes before we get things started. The first is that all attendees will be muted for the duration of the webinar so we can avoid any interference with audio. We will have a question and answer session at the end of the webinar though, and we encourage you to submit questions by typing them into the question box in your GoToWebinar control panel that should be on the right-hand side of your screen. We'll gather those questions throughout the webinar, and then at the question and answer session, I'll read them out. So please, submit them as they occur to you. If you have any technical difficulties, you can let us know by typing that into the chat box. And also, this webinar is being recorded, and we're going to share the recording with everyone who registered. So keep an eye out for that coming to you in the next few days. So with that, because we do have a lot of material to cover, I'm going to introduce our first presenter, Laura Reichenbach. Dr. Reichenbach is the Senior Associate at the Population Council and Deputy Technical Director for the Evidence Project. The Evidence Project is a USAID-funded implementation science project on family planning and reproductive health. Prior to joining the Population Council, she was social scientist and director of the Center for Reproductive Health at ICDDRB, an international public health research institution in Bangladesh. Her research and publications address a range of reproductive health issues, including family planning and unintended pregnancy, maternal health, cervical cancer, and STIs and HIV. So with that, Laura?
Great. Thank you very much, Kate, and good morning and afternoon to everyone on the webinar. This webinar is a follow-up to a satellite session on implementation science for family planning and reproductive health that the Evidence Project, FHI 360, and the Traction Project at URC jointly organized at the International Conference on Family Planning last year. That grew out of the identification of the need for sharing experiential learning of how implementation science approaches can help to improve family planning and reproductive health policies and programs. Today's webinar builds on that session and specifically highlights the role of implementers and policymakers in implementation science, and you'll be hearing 2 great examples of this today. The purpose of my presentation is to briefly highlight some common understandings of implementation science to set the stage and foundation for the examples that will be presented in the webinar. I'm going to provide a broad overview of the rationale for implementation science, highlight what makes it unique, and mention some of the challenges associated with implementation science approaches. So let's start by discussing why implementation science is useful and important. There is growing attention to the recognition that despite a large body of evidence about what works in terms of health interventions, the process of trying to replicate these remains a challenge. This is often referred to as the no-do gap. Often, evidence about what does work is generated in highly controlled settings of research trials or pilot projects or interventions. And replicating or scaling them up in different settings requires understanding the context and complexity of the implementation process itself. Finally, there's increasing demand for and pressure for evidence utilization given contexts of limited resources. As many of you are probably all too aware, there are a range of definitions of implementation science, and I'm sharing here a few different institutions' definitions, which include a range of perspectives, including USAID, the NIH Fogarty International Center, PEPFAR, and a recent consensus statement on implementation research and delivery science coordinated by the WHO Alliance for Health Systems Policy Research, the World Bank, and USAID Traction Project. While these definitions differ, I want to highlight where there are similarities across all of these definitions that create a common rationale and understanding of implementation science. implementation science is its focus on research utilization, or the translation of findings and evidence, and engaging with stakeholders to ensure that the evidence it generates is used and informs programming, and you will be hearing more about this in this webinar. So one can think about sort of the overall goal of implementation science as focusing on questions of how implementation can best be conducted in order to accelerate the adoption of evidence-informed interventions to change practice patterns at the provider level, health behaviors at the individual or community level, or overall policies, with keeping the goals of sustainability and scale-up in mind. So what are some of the characteristics that set implementation science apart from other approaches? I'm just going to highlight a few that I think are useful and important. One is that it's not just one single methodology or type of inquiry. It is truly multidisciplinary and transdisciplinary, and very much driven by the question or issue at hand. The outcomes it addresses are not necessarily measured just in terms of the health impacts, but often as broader system factors such as coverage, equity, and costs, for example. Importantly, implementation science takes place in existing healthcare systems or within networks of stakeholders. It takes place in the real world rather than controlled settings. It has a very strong focus on context, in part because it does take place in the real world, and it requires an iterative and a collaborative process to engage a range of stakeholders to understand that context. Implementers, beneficiaries, decision makers play a critical role, and it's very much driven by implementers and can directly inform decisions or be embedded within processes to address implementation barriers. It supports a culture of continuous learning, so it needs to be flexible and adaptive to reflect real world settings. And finally, as I mentioned before, it has a strong focus on utilization of evidence and research. So implementation science approaches are certainly not without challenges, and I just want to highlight a few here. I think some folks on the webinar may be aware that there's some confusion over what implementation science is or what it is not, and there is the use of different terminology, which means that there may not be as common understanding as there could be. This could be further exacerbated by how implementation and research communities understand implementation science and how they view their respective roles in engaging implementation science. It brings together what are sometimes unnatural partners. It definitely involves groups that don't necessarily have a lot of experience or natural contact working together. For example, certain researchers and implementers, or even with researchers from different disciplines that ultimately speak different languages. So there's a process of getting to understand and know each other. Funding sources may cross both research and implementation program budgets. And finally, because of the focus on context and real world, adaptation in real world settings can be methodologically challenging. And I believe our next presenters will be providing some examples of how some of these challenges can be addressed and overcome. And I will stop there. Thank you very much.
Great, Laura, thank you so much for that introduction. That's a really important framing of the issue that we're talking about here today. As I mentioned at the beginning, we're going to be holding all questions until, we're going to be responding to questions at the end, but I have seen a few come in. Please do feel free to continue to submit those questions in the questions box on your webinar panel. I'd like now to introduce our next presenter, John Standback. Dr. Standback is an internationally recognized leader in research and testing of innovative family planning practices. He brings nearly 30 years of experience in research and policy to his current role as senior scientist at FHI 360. Dr. Standback is also an adjunct professor in the Department of Maternal and Child Health at the University of North Carolina at Chapel Hill. And with that, I'm going to turn over to Dr. Standback for his presentation, The Power of Implementation Science, Community-Based Provision of Injectable Contraceptives in Sub-Saharan Africa.
Thank you very much. Thank you. I'm not seeing my screen.
Yeah, John, can you pull up the slides from your laptop if you can pull up your presentation? Great.
Thank you. There we go. Thank you. This morning, can you see that?
Yeah.
This morning I'm going to talk about implementation science in the service of family planning, and in particular community-based provision of injectable contraceptives in Africa. By this I mean training community health workers to safely provide injectable contraceptives, which are the most popular method in Africa, as part of the normal range of methods they provide, things like pills and condoms. This is not a new idea. It started more than 40 years ago in Bangladesh, and by the 1990s had spread to Latin America. But it's only within the last 10 years or so that this practice has gotten a toehold in sub-Saharan Africa. This is due in large part to a number of implementation obstacles, such as weak infrastructure, resistance by professional associations and conservative ministries of health, and simple concerns over the ability of community health workers to do this job safely. FHI 360 conducted pilots and studied this issue over a number of years, largely under the USAID-funded Progress Project, and much of the research that we did could meet the definition of implementation science. Speaking of definition, many of you are familiar with this table of implementation science outcome variables that comes from a popular guide to implementation science in health. It lists a number of implementation outcomes, and you'll notice it lists them in alphabetical order down the left-hand column. I've taken these same outcomes and put them on this arrow or arc, and with sort of a hierarchy of order, starting on the left at the bottom with outcomes you might measure in a pilot early on, things like feasibility and acceptability, and then moving up the arrow to more mature programs or to scale up, you start to measure things like cost and coverage and sustainability. So today I'm going to move us up the arrow and using examples from the research that FHI 360 did on community provision of injectables. And I'll start with feasibility. And I'll start with one of our early pilots in Madagascar, where CHWs were trained to add injectables to the other methods they were providing. This was a partnership with the Ministry of Health in Madagascar and funded by USAID. We looked at a number of outcomes, things like uptake and acceptability, but we had a real focus on on feasibility, and we had various measures of whether the practice conformed to quality standards and whether there were systems in place to support the practice. Moving up the arrow, most of the countries where we did this research, we looked at acceptability, and a very good example was a pilot conducted in Zambia, again with USAID funding and in partnership with the Ministry of Health and Child Fund. Again, we looked at quite a number of outcomes, but acceptability was a big part of it, and what we found was that the practice was extremely acceptable. Clients really liked getting their depot shots from their local CHWs rather than traveling all the way to a clinic and having a long wait. providers and clients and community members all found that the intervention was indeed appropriate, and Senegal did change their policy and scaled the practice up to more than 500 sites throughout the country. Fidelity to of the intervention to its original design and purpose becomes very important during scale-up. A good example of this was in Uganda, where we did the very first pilot way back in 2005, partnering with Save the Children and the Ministry of Health and funded by USAID, and we compared the outcomes of CHW clients with clients who got services in the clinics. And we had good results, strong results, looking at things like 6-month continuation of the method. But then 3 years later, Save the Children scaled the practice up to additional districts, and we went back and did the same measures in the scale-up districts to assess fidelity, and found that indeed the practice did stay faithful to its original purpose, and we had strong continuation. We also looked at satisfaction with care, acceptability, which we had looked at originally in the pilot, and then looked at again 3 years later during scale-up, and had similarly strong results. Cost is very important, but often difficult to measure. We did measure it in Zambia and looked at the incremental cost per couple years of protection, CYPs, from adding injectable contraceptives to the existing program. We calculated that each additional CYP costs about $11, which does not sound cheap and isn't very cheap, but in the context, there weren't too many CYPs being produced prior to the community health workers being allowed to give the injections. The clients really did not want the pills and condoms that were offered. What they wanted was injectables. So the ministry and Child Fund showed big jumps in CYP at that time. Coverage is obviously important as well. We measured that in a number of places. Kenya was a good example where we partnered with the ministry and JPIGO and Advanced Family Planning with funding from USAID and Gates in Tharaka District, and the Tharaka District had strong service statistics that we were able to use, as well as census data, and we were able to calculate that prior to the intervention, modern contraceptive prevalence was only about 9%, but that after the local community health extension workers were trained to provide injections and started doing that, and started also doing more referrals for long-acting methods, prevalence increased to about 46%. This has been mirrored in other findings from over time from Bangladesh, for example, way back in the 70s, and more recently in Afghanistan. And finally, sustainability, again, difficult to measure and even controversial about what it means, but to the extent that scale-ups can serve as a proxy for sustainability, this is the situation in Uganda in 2005 in the original pilot, where we started with 1 district. 3 years later, the practice had scaled up with different organizations and to about 7 districts, and today I think more than half of the districts in Uganda have injectables being provided by village health teams. Similarly, on the continent as a whole, starting in 2005, there was only the single pilot happening in Uganda. By 2009, other countries were piloting and showing interest in this practice and even changing their policies. By 2012, the map is filling in more, and the blue colors are becoming darker. And by 2015, we had quite a bit of coverage of this practice, a good bit of which is due, at least in part, to implementation science. So I'll leave it at that, and thank you all very much.
John, thank you so much for that really fantastic presentation.
Can't hear anything.
John? Sorry, you all. We were having a little bit of trouble with the audio on this side. John, that was a fantastic presentation, and really showed us, illustrated different studies and the progress of implementation science over that arc. For the next presentation, we're joined by 3 panelists: Dr. Emily Pekka, Dr. Wangui Musagani, and Dr. Walter Odoch. Dr. Pekka is an implementation research scientist for the USAID Translating Research into Action project, which is based at University Research Company, LLC. She provides technical and research management support to partners for the advancement of implementation science, particularly in the areas of respectful maternity care, quality of care, and task sharing. Her primary area of focus has centered on improving access to and utilization of high-quality reproductive, maternal, and newborn health services in developing countries. Dr. Musagani is a program manager in charge of maternal and newborn health at the Ministry of Health in Kenya. She is a medical doctor with an expertise in health systems and policy, and spearheaded the development and implementation of the National Maternal and Perinatal Death Surveillance and Response Guidelines. She also led the development of the National Maternal and Newborn Health Implementation Plan, a blueprint of high-impact interventions in scaling up maternal and newborn health in the counties following decentralization in 2014. Dr. Musagani has been at the forefront of scaling up respectful maternity care from operational research to national policy and implementation in all counties in Kenya. Dr. Walter Odoch is a Senior Program Officer and Acting Manager for Health System Strengthening and Development with the East, Central, and Southern Africa Health Community. He is a health policy specialist with over 10 years' experience in health systems development. Dr. Odoch supports ECSA member states in harnessing initiatives for health system strengthening with a focus on universal health coverage, health policy development, health financing, human resources for health, and pharmaceutical management. They are going to be moving quickly from one presenter to another. So with that, I'll turn things over to Dr. Pekka to get us started.
Thank you, Kate. It's my pleasure to kick off this presentation, which tells the story of how implementation science catalyzed action around the promotion of respectful maternity care at global, regional, and national levels. I will begin by sharing the global perspective of how respectful maternity care was thrust into the limelight, followed by my colleague, Dr. Musagani from Kenya's Ministry of Health, who will speak from her experience working on the issue in Kenya. And finally, we will hear from Dr. Odoch from ECSA, who will demonstrate the value of engaging regional institutions to influence policy and advocacy around respectful maternity care. Back in 2009, there were interest among colleagues at USAID to further understand and explore women's experiences giving birth in health facilities. Until this time, disrespect and abuse during childbirth in health facilities was widely known about, but not named, and little evidence existed. So the plan was that there was a need to capture the breadth and scope of disrespectful and abusive maternity care, and this was done by commissioning a review of the available literature, both gray and published, in the form of a landscape analysis. Then, in order to further legitimize this effort, there was an emphasis on linking disrespect and different categories, or 7 different types of negative experiences facing women who give birth in health facilities. And you can see these here. This was incredibly critical because it provided the first name and frame that helped to inform subsequent research and advocacy efforts. What followed were the first examples of implementation science efforts to better understand disrespect and abuse and how to advance respectful maternity care. The USAID Translating Research into Action project supported the first 2 major projects in this area. One was called the Heshima Project, which was led by Population Council, the National Nurses Association of Kenya, and the Federation of Women's Lawyers in Kenya. And the second was the SAHA Project, led by the Averting Maternal Death and Disability group at Columbia University and Ifakara Health Institute in Tanzania. These 2 teams had a very ambitious task before them. They were charged with developing tools and quantifying and describing disrespect and abuse, designing approaches to address disrespect and abuse and to promote respectful maternity care, and then do evidence generation around the implementation of these approaches. The result or the objective was to create new evidence around how to measure and how to implement approaches to address disrespect and abuse. While this was happening, many other efforts were taking place as well. The White Ribbon Alliance from the beginning launched their charter of the 7 rights of childbearing women, which was building off of the typology of disrespect and abuse that came out of the landscape analysis. This has been an important tool in terms of advocacy and awareness raising. A few years later, the World Health Organization released their statement on the need to prevent and eliminate disrespect and abuse. In the past 5 or 6 years, we've seen much more literature emerging in terms of anything from a new typology to commentary and thought pieces, and more implementation science and research around mistreatment or disrespect and abuse. We've also seen a shift in our conceptualization of quality, partially influenced by this work, where now the framework for quality of maternal and newborn health care put forth by the World Health Organization has put women's experiences of care on par with the provision of care. So we see that many different efforts have been happening in parallel and reinforcing action around this issue. So with that, I'm going to turn the presentation over to my colleague, Dr. Muthigani, who will speak about her experience working on promoting respectful maternity care in Kenya.
Okay, thank you so much, Emily, and thank you for the opportunity to make this presentation where we get to share Kenya's experience with implementation of respectful maternity care into policy and implementation in Kenya. So Kenya has a national maternal and newborn health implementation plan, which has 6 key objectives that mirror the 6 building blocks of the health system. One key area that we focus on is strengthening provision of quality maternal and newborn health services, and the need to deeply delve into the experience of care in terms of respectful maternity care. How this got embedded into policy was through the Heshima project, where the Ministry of Health took lead in research implementation. So MOH was involved in development of the research tools for the Heshima project, training of data collectors, supervision and analysis of the data, and thereafter interpretation of data to information that leads to decision making. So from the baseline results, dissemination was done amongst the maternal and newborn health stakeholders in Kenya, and also among a broader range of stakeholders that are involved in maternal health outside the health fraternity. And this led to development of interventions based on the findings from the Heshima project. Now, one of the interventions was a package for respectful maternity care that has the community health package. We have a facility-based training package which has a participants and facilitators manual, and RMC is currently embedded in the maternal newborn child health bill that will be presented to Parliament later this year. And we did not stop at just having the package. We periodically share our research findings with the MNH technical working group and our steering committee at national level. So from this, we learned that we need to focus on community engagement and institutional visibility, including information and counseling for the vulnerable groups, including adolescents and the members of society who have physical and mental disabilities. We also focused on improving customer care skills amongst our healthcare workers and the front desk personnel at facilities. Further, we prioritized caring for the carers approach, where we recognize that our healthcare workers need debriefing sessions and motivation in order to give the best services. And we're now scaling up nationwide, where we had started with a few facilities, went on to about 5 counties. Now we've rolled it out to 13 counties, and we're aiming to reach full coverage of the country with 47 counties, and having RMC embedded in the pre-service curriculum at our medical training colleges and medical schools. We also have more partners working on respectful maternity care together with the Ministry of Health. We have a lot of support from USAID, from DFID, UNICEF, WHO, World Vision, and JPIGO, just to name a few. And with this, I'll hand over to Dr. Walter. Thank you so much for listening.
Thank you, Dr. Muthigani. Now we'll move to Dr. Odoch, who will talk a little bit about the opportunity to leverage his regional platform at ECSA to continue advancing respectful maternity care.
Thank you, Emily and other colleagues who put this meeting together. Just briefly about ECSA. ECSA is an intergovernmental health organization. Was established in the 70s, basically to promote and foster regional cooperation in health. And currently there are 9 active member states. And one of the most maybe key areas where ECSA is important is in terms of convening the different technical and policy makers from the 9 ECSA member states in order to fulfill its mandate of fostering regional collaboration in health. And it derived influence in this area. So in terms of implementation research or implementation SaaS, it really provides an opportunity for sharing results and inter-country learning of what is working well elsewhere. I think, as John indicated in a slide, in Africa we saw a lot of things cropping up, building countries adopting or adapting things done elsewhere. At a regional level, when such kind of evidence is presented, it makes the countries to also copy what other member countries are doing. In the next slide, basically, Kenya, that has a clear policy, has tried and has progressed, has scaled up. What can other countries learn from? So ECSA comes in to provide such kind of platform where we are able to share this evidence at a regional level and countries to learn from one another, but also more importantly is that the countries within the same contextual settings can be able to feel some kind of pressures to do the good thing that their colleagues are doing from within the region. So there are a lot of comments, particularly on the aspect of RM respective maternity care. I think, as Dr. Wangui has indicated, we did realize that the issue of respective maternity care is not new, but implementation research or science tries to make it in a framework that is easy for everyone to understand and debate and try to chart a way forward. And the problem has been there, the problem of irrespective maternity care has been there within the region and outside the region, but now we are in a good situation where we are generating this evidence, and this evidence is expected to inform the future policy. From the ECSA perspective, in terms of the next step, it will going to provide the opportunity for discussions, for sharing the experiences happening in other places, and also for putting a kind of soft pressure on our member states to adopt the practices which have been proven to be effective in scaling some of the good interventions and practices done elsewhere, either within the ECSA member state or outside the region. And it was also recognized that, particularly when it comes to respective maternity care, there are other issues. It is a multi-sectoral issue. It's not only within the health sector. Working with other regional bodies and the member states are important in that area, but also coining it so that it's not looked at as trying to blame the others, like especially the health workers. As you're aware, when it comes to this area, mainly you'll be talking with the health workers, but to put it in a way that we recognize that it is beyond the healthcare system alone or the health workers alone. So I think these are some of the good things when it comes to implementation research, that we are able to bring this evidence and present this evidence to a wider stakeholder at a regional level as we push for at the global and also at the national level. So thank you.
Thank you. Thank you so much, Dr. Odoch. I think in conclusion, what we've learned so far throughout this process is that successful implementation science efforts are not linear, and they require much more than just evidence generators or researchers at the helm of the effort. It's critically important to also involve users of implementation science. Finally, to move evidence into action, strategic engagement of advocates, policymakers, implementers, and researchers are needed all throughout the process to make these efforts successful and to translate implementation science findings into action. Thank you.
Thank you all so much for those fantastic presentations. We've had a couple of questions come in. Excuse me. So the first question is directed to Dr. Mithagani, and that is, from the policy and program perspective, what factors made RNC efforts so successful so quickly? So sort of what might have made that different, and then even more importantly, what do you want researchers to learn from this example? So researchers in other fields, what can they take away to make their efforts as successful as RNC?
All right. So from the Kenyan experience, one of the key factors that has seen RMC successful and in such a short time was involving a lot of our key stakeholders in every step of designing the research, data collection, implementation of respectful maternity care, and this saw it get embedded in our policies as a very key intervention in improving maternal and newborn health. Further Kenya took on the approach of having a patient-centered health system. So it took us a step back from the health system being at the center of everything to having the patient as the key to improving healthcare. And this changed our way of developing policy and developing our M&D systems. Therefore, it came naturally that respectful maternity care was of interest. It highlighted a key area in improving the quality of maternal and newborn health. And with the wide scope of health and non-health actors involved in the whole process of designing RMC, we saw it have an accelerated acceptance into the health system. So right now we're working at getting the frontline healthcare workers embracing respectful maternity care, and lastly also involving the community at every step of the way has contributed greatly to having RMC a priority in MNH.
Great, thank you so much. That's a very helpful answer. And I'll take a quick moment to note for those who have asked, we are going to be sharing a recording of the webinar in a few days once we've had a chance to get a link up on our website. So those will be coming out, and we're hoping that we can put the presentation slides up with that at the same time. And I also want to note that when I'm thinking about the RNC example, there's sort of a parallel to what Laura said about implementation science being not just the what, but also the how. And RNC is really not, has a parallel. It's not just what care is delivered, but how is that care delivered. I think that's sort of a nice synergy there. So the next question, John, is for you. And the question is recognizing, so we just talked about how fast RMC happened, and it really seemed to have fit with a window of opportunity there. But you highlighted something that's been happening over years and has really built a lot of success by working over a longer period of time across multiple countries. And the question for you is, how do you maintain and build on momentum for those bigger lift or longer term efforts?
Wow, that's a great question. And I guess I've been working in this area long enough to learn that one of the skills you really need is patience, because change often takes time. But there are things you can do to speed it up. One of our mantras is always that we always try to begin with the end in mind, and thinking early and often about what you can do to make it real for the stakeholders, and what it takes to convince them space, and which made it easier, an easier lift, as you say, to change the policies as we went along.
Great, thank you, John. Yeah, that point at the end, the consistent funding, a lot of it comes back to that. But I also, the beginning with the end in mind, you've illustrated what that can bring back if you do start with that in mind. So the next question is for Laura. The next question is for Laura, and the question is, sorry, just a second. Okay, sorry, so the question is for Laura and John. There's nothing. Okay, so what are the similarities and or differences within implementation science or implementation science and implementation research in the context of moving from small-scale pilot operations research to scaling up? So how does translational research correspond to implementation science paradigms? Laura, I'll give you the first crack at that.
Wow. Okay.
John, you can take the second.
John, I hope you'll be backing me up. That's a great question, and I think these are, some of the questions that continue to come up, and I alluded to that a little bit in my presentation in terms of the multiple definitions and terminologies. And I think it is really important to understand and make some of the distinctions. I think that, I do think that John's presentation was really useful in highlighting that arc of the implementation research, which I would argue includes those pilots and more sort of operations research. I think implementation science, as I mentioned, is a really large toolkit in terms of the types of methods or the types of approaches that are used. And the decision about what sort of design is really driven by what is the research question or the implementation issue or concern that's being addressed. So it's really kind of driven by that process. The question also mentioned translational research. I think it's important to mention that we're talking about implementation science in the area of global health. There's a huge literature and a lot of work that's been done in the United States and in other countries, and really grown out of more of the translational science movement, I would say. So there are linkages. I think we're today really just focusing on these examples here. But I would love for John to correct me or better answer the question.
Oh, well, thanks, Laura. And I probably can't add too much to what you said. The definitions for implementation research and implementation science that we get from NIH, and as your slide showed, can vary so much. Here at FHI 360, we have our own criteria for what is and what isn't implementation research, and I won't bore you with those, but it can include pilot studies when you're looking at the testing, the feasibility, or planning a complex intervention, or when not much evidence exists on a given topic. So I probably can't answer the question directly, and I'm not a formal methodologist, so I think I'll stick with what you said.
Thank you both. So the next question, Laura, is for you, and it's a question about what are we doing to prepare the next generation to conduct implementation science research, and yeah, what sort of efforts are going on there?
Wow. Okay, that's a really that's a great question. It's a really important question. There's certainly a lot of interest and demand, I think, for training and capacity building related to implementation science and implementation research. I will mention that in the first 2 years of the Evidence Project, we collaborated with the University of Washington in offering a 2-week course. It was an intensive course, 2-week intensive course on implementation science for family planning and reproductive health that really tried to focus on both learnings around the methodologies, but was also very practical in terms of designing an implementation research science protocol. Those were very well received, and I know the University of Washington Department of Global Health has an online course that I think goes for a couple of months. I think that's relatively new, and I would recommend that people look to that. But I think there's more and more discussion about the trainings for implementation science, both in formal programs of public health, but also looking for opportunities for other types of capacity development.
Yeah, just to build on that comment, I think in addition to documenting the how and the why of implementation, think we need to do a better job of documenting our experiences as implementation researchers. And we're at the beginning stages of pushing for the development of things like learning case studies around implementation science and other things like that that can be shared and used either in classrooms or for the benefit of practitioners in the field.
I think that's an excellent point. The more we learn about experiences with implementation science, I think the more people understand not just what it is, but also what it can do. I think, you know, the concrete examples and experiences show you what it can achieve, the successes. It also shows you what challenges you need to be prepared for. So we have time for one more question, and Emily, Dr. Peck, I'm going to direct this at you. You mentioned, you know, you talked about the multiple efforts that were going on at global, national, regional levels, and this is probably thinking a little bit more about the global level, but wanted to ask you about the role of advocacy, because you mentioned that it wasn't just research going on, that there were advocacy efforts at the same time.
Sure. I think the key to success in this area was taking a broader perspective from the beginning and thinking about how we needed to get advocacy launched in parallel with the evidence generation so that we're increasing the demand for knowledge around implementation science while generating it at the same time. And it was the interplay between the advocacy and push for more information while generating information that I think really catalyzed different efforts, whether it be at international organizations like the WHO or other advocacy organizations, and more research efforts as well. So I think thinking about the types of stakeholders like advocates from the very beginning and how you need to strategically position and engage them throughout the process is what really made this effort and continues to make this effort successful.
Great, thank you. So I recognize that we are coming to the end of our time here today. I want to respect all the presenters' time and thank them so much for their contributions. Before I wrap things up with the last few notes, I wanted to ask Dr. Adoch and Dr. Mutagani if you all have anything that you wanted to add.
From my side, I think there is nothing particular, but maybe I want to just put forward that some of the issues that bedevils other type of research, I think even implementation science, as we've seen from our discussion, is not immune to them in terms of actually when you do the pilot, to make it faster or to move a little faster into the practice or policy, it is not something which is from the experience within the government bureaucratic process, not something also which is not easy. I don't know in particular whether the implementation scientists are also observing that actually it will be an area of argument with the other kind of researchers. We have seen the traction project that we are working with Emily and colleagues. Point out.
Okay, and what we've learned from the experience with respectful maternity care implementation is having the community and the patient at the heart of improving quality for maternal and newborn health. It's shown to have greater and lasting impact, positive impact to the community, to the health facility, to the program in general, as it starts at the point of where it's needed most with the patient. Further, I think at Kenya we've learned to be very flexible and very inclusive in our stakeholder engagement. Very flexible in how we develop policy and take it step by step, and having a phased approach has really shown great great results for implementation of respectful maternity care. Thank you.
Thank you so much, Dr. Mithagani and Dr. Odoch, for those excellent points. So recognizing that we are at the end of our time today, I wanted to thank everybody for joining us, especially the panelists for taking their time to share their experiences with us. As a reminder to those of you who joined us today, we are going to be sharing a recording of this webinar in a few days. So if you had to join in the middle, you can get the full presentation later on at your leisure. I'd like to thank Population Reference Bureau for hosting us today, for the Traction Project, the Evidence Project, and FHI 360 for all of their learning and sharing it with us today. Thank you all and have a wonderful day.